Here's a quick video of somebody with 3 symptoms. Knee pain, 4 years, trigeminal neuralgia, 12 years, and IBS, 20 years. And watching the process of change in those things is fascinating. Hi, my name is Drew Coverdale. I'm a physiotherapist to help patients with persistent pain. This is primarily from a musculoskeletal perspective. That's my background, the bones, the joints, the muscles, like a physio normally assesses. But in the realm of persistent pain, you tend to see other systems being overloaded as well. Persistent pain is something that lasts beyond 3 months, 3 to 6 months if you allowed the grace of some additional conditioning that maybe needs to take place if you've been off for a while. But if there was injury, the time has passed for that tissue to have healed. If there was no injury and the pain came on without an explainable cause, quite often there's other drivers to that pain rather than the physical place you feel it, or rather than the physical movements alone that might influence it. Doesn't mean that the movements in the part of the body where that pain's felt shouldn't be assessed and examined and any changes there respected, but there are other things at play that need investigating, and if you can be open to that idea, you can recover from pain in those parts of your body. This lady presented with 4 years history of knee pain that happened after dancing on a night out. She woke the next morning with knee pain. She thought she'd sprained it, had it assessed, didn't get any better with physio and conventional treatment and rest and exercises and everything she was told that she should do, and the pain persisted 4 years later. So that's a bit unusual, isn't it, when they don't find anything to do surgery for, and they've done all the exercises and she's still got this pain. Now when you look at what else is going on, she has a history of trigeminal neuralgia, which is a facial pain, a jaw pain, and linked to the nerves in your head. And she'd explored that from treatment perspective, and they basically said to her, live with the pain, manage with the painkillers. The only option is to drill a hole in your skull around this nerve and release it, which she didn't want to have done. So she managed that pain. She also had a pain 20 years of IBS, which is another condition that you investigate to the nth degree, and generally they find nothing worthy of pathological disease process worth where they can do anything about. So it's another condition they have to manage with medications, and both of these other conditions are managed with medication, and a knee pain is also managed with medication. So the medical viewpoint is that you accept the diagnosis of why these pains are ongoing through that label, but we can't do anything about it, so keep taking the tablets and manage the pain. Look at the traits of this person. She's very driven, very self-sacrificing, pushes through, sees pain as something to beat and overcome and fight. Lovely traits for short-term battles and events and overload. Not good for a perpetual pattern of behaviour, full stop. In the presence of any difficulty, any challenge, trauma or overload, a sense of overwhelm, you've got to have some rest. If you don't know how to, have never been taught how to, or never seen people in your family unit have known how to or done, well, how would you know any different other than to do what's normally conditioned in that family unit? So we start to present the cause of this pain, or the contributors to this pain, back to this lady, and this is about 5 or 6 weeks ago. Primarily using the knee as the focal point of how she symbolises attending to herself. So it can represent exercise, it can represent movement, and it can represent positions and places where she just takes it a little easier. But the knee doesn't change immediately. But when she starts considering the stresses in her life as influencing the knee and starts to control them, when she sees how she pushes hard with the knee and starts to regulate that, when she starts to notice simple things she can do by downgrading the reactivity of her own nervous system, by slowing down her breath, slowing down her thoughts, and slowing down her movements, and then slowing down her emotional reactions to situations, saying no, pausing, resting at the end of the day, having breaks at work, The knee pain hasn't yet changed, but what is interesting, the IBS symptoms have started to change. The neuralgia pain, she's using less medication. So although the focal point is the knee, can you see how once the overall system sees change, then the pain and the symptoms start to almost melt without giving them overt focus directly on the neck and the trigeminal neuralgia, directly on the IBS. And those symptoms, they're outside of my realm as somebody who's a medical practitioner. People come with physical pain, but when you start these other things, when you start the process, you just notice things start to change. I'm indifferent to the outcome of the knee because I know conclusively there's nothing structural in the knee that is preventing this lady from doing the things she wants to do. There is pain there. It is always real. It is always quick and reactive and disproportionate, but it won't be forever. Once the nervous system, in the context of the knee and on the background of everything else settling down, starts to hit a threshold of safety, there'll be gaps in her pain. And if what we've done so far, and what I encourage everyone to do, is bed in the baseline calmness first before you start to push. Let your nervous system see this new behaviour, let it react to it, and making sure that you could categorically say what you've done isn't dangerous and reassure yourself of that, and then you start to take it towards the triggers. And that's the next for her knee. So physically we push the knee a little bit more now, knowing it's fine, absolutely fine, knowing that she's doing this on the background when the trigeminal neuralgia is easier, the IBS is easier, she's generally sleeping better and she's happier. Bring on the rest of it. So the less you focus on the actual pain, the less you focus on it, and the more you focus on being consistent with the habits, that's when the magic happens. It doesn't have to happen all in one go, and it might not happen in the predictable way that you or the clinician helping you might expect, but just be open to the idea of change, and it can happen.